Thanks, Lana. Welcome, everyone. Thanks for joining us on our first Lunch and Learn speaker series. Today, we are excited to have Dr. Ba and Dr. Martino join us. But quickly, I'm just going to say a couple things about Parkinson Awareness Month and April. So this April, we want to contribute to help educate and raise awareness to the fastest growing neurological disorder in the world, like Lana mentioned, and we want to celebrate our resilient Parkinson community. We are unshakable. Unshakable describes something that's firm, steadfast, or not easily affected by change or external factors. And this term is often used figuratively to describe qualities such as confidence, determination, and resilience. And I think that really describes our Parkinson community here in Alberta. And so this is our theme for Parkinson Awareness Month 2024. For us, Unshakable describes the spirit and resolve of people living with Parkinson and Parkinson plus diagnosis and their friends, families, and support network. Parkinson's researchers, clinicians, allied health professionals, program partners, community advocates are also unshakable in their support of those affected by Parkinson's. The team here at Parkinson Association of Alberta is unshakable in our commitment to our remarkable community. This month, as Lana mentioned, we have several activities planned in addition to these noon hour webinars, which are happening weekly. We have spring socials happening across Alberta, so we'd love to see you there. And if you'd like to join, you can go to our website and find the dates and times listed of the socials, or you can always call us at our toll-free number, and we'd be happy to give you that information. We'd love to see you there. As you probably know, April 11th is World Parkinson Day, and we are celebrating by turning the province blue. So many landmarks and locations across Alberta will be lit in blue on the evening of April 11th, next Thursday, as we join organizations around the world to light the world blue. April 11th is also our Stand Up to Parkinson event, which is taking place at West Edmonton Mall and Calgary City Hall. And we encourage you to join these events where we'll be holding some really fun activities, a pancake breakfast, and getting you involved in our Sit and Stand challenge. Our aim is to do 10,000 stand-ups on April 11th at those locations. And if you'd like to get involved, we'd love to have you, of course. And you can join us by going online to register for our website or again, calling our toll-free number, which we'll put in the chat. All right, that's exciting. That's all happening in April, but let's get to today. So for our webinar, if you have any questions throughout the webinar, please submit them in the chat below. There's a little icon, that's a little chat icon there. You can click it and then your questions will go in there and I will read the questions to our moderators after the presentation. Just as a disclaimer, this webinar is recorded and all the information provided in the videos by Parkinson Association of Alberta and our featured speakers are furnished strictly for education and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. General questions about symptoms, treatments, available medications, complementary and alternative healthcare therapies, and current research will be fielded. We are very excited to have Dr. Ba and Dr. Martino join us today for our webinar. And so I'll do a brief intro for both. So Dr. Ba received her MD degree from the University of Calgary in 2007. She also obtained her PhD degree in physiology and neuroscience from the University of Alberta. She's finished her neurology residency and the CIHR fellowship in movement disorders at the University of Alberta. She has also pursued further training in deep brain stimulation at the University of Florida. Her research and interest and practice are in DBS and the movement disorders. She is currently associate professor in the Division of Neurology at the University of Alberta and the director of the Parkinson and Movement Disorder Program in Edmonton. Welcome, Dr. Ba. We are also joined by Dr. Martino, who is an associate professor and director of the Movement Disorder Program at the Hotchkiss Brain Institute at the University of Calgary. His research program focuses on biological markers, environmental factors, and multidisciplinary pathways of care for complex movement disorders, mainly dystonia, Tourette syndrome, Parkinson's disease, and essential tremors. So welcome, Dr. Martino. I'll pass it off to you guys.
Davide, do you want to go first? Because we talk about one project and you will talk, I won't talk. So I let you go first.
Okay, I will go first. All right, I will thank you very much to PAA for having us today. I will start by sharing my screen. Seems like are you seeing the PowerPoint?
Yep.
Yeah, so I'm just gonna, all right. And are you seeing this in presentation mode now? Okay,
yep.
Great. All right, so again, thank you. And I will be talking to you a bit about what's going on in the research on Parkinson's disease in Calgary. And I'll start by introducing our team of clinicians and investigators based in Calgary that form the group known as Calgary Parkinson's Research Initiative, or CAPRI, within the University of Calgary and the Hotchkiss Brain Institute. Now, what CAPRI is, some of you may have heard about it, and some of you may have already been involved in research activities run by it. This is really an infrastructure to initiate and accelerate bold and groundbreaking projects to improve ultimately management and treatment of people with Parkinson's and related disorders. It does include a registry of patients, a biorepository, and it's tightly networked with the Canadian Open Parkinson Network, or C-Open. As you can see, this is just a snapshot of the. It's a non-exhaustive picture of the different investigators that are involved, but these are really the folks who are running this initiative. And as you can see from the themes that revolve around their names, this really touches different aspects of research in Parkinson's, from understanding the basic mechanisms of the molecular and cellular processes in underlying Parkinson's, all the way to innovative neuromodulation techniques and strategies, understanding better the role of cognition, as well as therapeutic clinical trials, advanced care programs, and of course, education too. So I'm going to give you some general examples of some of the colleagues that were happy to be sort of like pitched in their activity and within CAPRI, just to give you an update of what we are currently working on in the field of Parkinson's in Calgary. This is a very difficult slide, and I promise I won't have too many of these. But this is, well, I'm going to walk you through it. This is work coming from Dr. Jocelyn and Dr. Park's labs that is really focusing on specific molecular mechanisms in Parkinson's. And this lab is making important discoveries on how certain variants of genes, or you can call them mutations of genes that are related to Parkinson's, can contribute to the loss of brain cells, and particularly neurons that produce dopamine, which are particularly struck in this condition. For example, the graphs on the left show basically summarize the evidence that variants of a gene called PINK1 can affect mechanisms that protect neurons from the damage caused by inflammation, by a cascade of inflammation. And the loss of these protective mechanisms can lead to an accelerated loss of dopaminergic neurons with aging. On the right, these are graphs that summarize the experience and the evidence in respect to the effect of another gene involved in Parkinson's, probably the most commonly associated with Parkinson's, called LRRK2. Which instead causes an excessive activity of another brain cell type called microglia, which is a bit the immune system patrol in our brain. And in particular, what happens with these mutations is that certain activities of microglia become excessive, and one of them is called phagocytosis. It's a mechanism that over-digests bits and pieces of neurons in an excessive way and detrimental way. And this is interesting because this lab has shown that it's not just the people bearing this genetic variant of LRRK2 that have this issue, but this could be happening across people with sporadic Parkinson's disease that do not have a genetic form of the condition. And now, what is important is that this lab is selecting molecules that can inhibit this phagocytosis process. And they have started looking at molecules that are already approved and used for other purposes in medicine, and could therefore be repurposed to treat basic mechanisms like this one. So this is the approach of drug repurposing. And it's an example of how understanding better the mechanisms in Parkinson's could lead us to identify drugs that already exist and that can be simply tried in Parkinson's disease to see if this can slow down the acceleration of the progression of the condition. And certainly the advantage of the drug repurposing approach is that it accelerates the process of finding new treatments because it doesn't have the same long time to wait for a large worldwide scale clinical trial to be completed and prove to be successful. There are shorter cuts to this process, and drug repurposing is one of them. Another example of work that we are currently doing stems from a different way to look at Parkinson's. Parkinson's, as you know, is a very complex and diverse condition. Every patient is different from the other, and there are different subtypes or forms of Parkinson's, if you will. And one interesting model that is currently being discussed, and in a way also increasingly endorsed, is a model that shows how the pathological mechanisms that lead to a brain cell loss in Parkinson's, or to symptoms in Parkinson's in general, can have different directions of propagation. So, for example, there's maybe two specific subtypes, one in which mechanisms of damage, mostly coming from aggregation of proteins in the brain, starts in one hemisphere of the brain and then spreads top down to the rest of the body. And we call this the brain first subtype. But there may be, on the other hand, a body first subtype where the pathological mechanisms start in the lower part of the brain or even outside of the brain, for example, in the gut, and then they can spread bottoms up towards the brain. And what is important is that these two different subtypes lead to different clinical presentation of Parkinson's. And therefore, almost two different conditions, even though they are accommodated by similar pathological mechanisms. So what we are particularly interested in is to see if the gut microbiome, so the microbes, the bacteria that live in our gut regularly, might contribute to steer the evolution of Parkinson's towards a body first or a brain first subtype. And we're doing this using animal models that are inoculated with stool specimens coming from patients with either body first or brain first subtype, and then observe how these animal models develop in their behavior presentation, in their motor function, in their cognitive function, in their olfaction, and in their immune system activities. And we're already seeing some important differences that are providing support to this model. But why are we doing this? We're doing this mostly because by understanding which type of gut microbiome change occurs in each individual subtype of Parkinson's, we can then design we can package and design an ensemble of bacteria that we need to repopulate in order to correct the gut microbiome imbalance that exists specifically in either of these subtypes in people with Parkinson's, and then test it as a therapy. So this is called designer microbial therapeutics, and it's something that could be exploited in the future as a way, a much more personalized and precision medicine-based approach to use gut microbiome or microbiota manipulation compared to the general fecal matter transplants or use of probiotics or prebiotics, or something that can be more specifically targeting the abnormality or the change that we observe in the gut ecosystem of specific subtypes of people with Parkinson's. But in terms of intestinal functions. Of course, there is the large intestine where most of the gut microbiota lives, but there's also the small intestine. As you know, the small intestine is a very, very important part of the gut because it's where digestion and absorption of nutrients happens in the vast majority. And microbes and bacteria live in the small intestine too. And interestingly, but these are very difficult to study because we can't rely on stool specimens to investigate this type of microbiota. But we now have the technology to do that using a capsule that almost like a spaceship travels across the gut, opens up in the small intestine, collects biofluid from the intestine, and then closes again and is then retrieved in the stool specimen. This is called the Simba capsule, and it's been developed by a Calgary-based company, Nimble Science, and we are using it to investigate how the small intestinal microbiota can affect the general function of the gut and possibly of the brain of people with Parkinson's, but also because we know that levodopa, the oral levodopa, the most commonly used medication in Parkinson's, can be digested and in a way destroyed by bacteria living in the small intestine. Part of the reason why some patients don't respond well to levodopa may be due to the fact that there are bacteria in their small intestine that are digesting levodopa. And by using this Simba capsule, we can correlate basically the presence of these bacteria to how well levodopa is absorbed in the small intestine of patients and how well it functions for these patients. So this is another reason to study the small intestine using the Simba capsule, and this MILE study is focusing specifically on this purpose. Changing a little bit topic, there are different external factors that are investigated as possible contributors to the development of Parkinson's. One of them is head trauma and traumatic brain injury. And these are particularly interesting because there is a condition called traumatic encephalopathy syndrome, or TES, that can present with Parkinsonism too. And one of our colleagues in the physiatry division, Dr. Chantal Debert, here in Calgary, is interested in exploring the relationship between this factor and Parkinson's disease. So this is actually quite interesting research that will be conducted in Calgary. Clinical trials, well, as you know, there haven't been a huge amount of new medications that have come out recently for Parkinson's disease, but certainly the newest addition as of this year across all Canada is the subcutaneous pump for levodopa. By now, most of you should already be familiar with the duodopa pump, which infuses levodopa directly into the small intestine, bypassing the stomach and the upper part of the GI tract. But this one actually bypasses the gastrointestinal tract completely because it's infused directly under the skin and goes into the bloodstream from the subcutaneous tissue. And Vialev, it's the name, and this has been recently approved in Canada. And our Calgary site has participated to the trial that led to its approval. And particularly Dr. Justina Sarna in our group has been particularly involved in this study and has more experience than any of us at the moment on this very new product. As you can see, the effect of this infusion pump for levodopa is that it decreases significantly the time spent in off, and increases significantly the time spent in on without dyskinesia or without troublesome dyskinesia, which of course is potentially leads to improvement of quality of life and functioning. And again, it's the same medication that we are already using, levodopa, carbidopa, only infused using a different route of administration. I'm going to touch on neuromodulation because this is a fundamental part of the present and likely and hopefully a substantial component of the future of the treatment of Parkinson's and other movement disorders, which depend on the dysfunction of specific brain networks. And Dr. Ba will probably mention this as she's an expert. I mean, two major methods that we are studying in Calgary are deep brain stimulation and focused ultrasound neuromodulation. Ways to use these neuromodulation technologies are, or research objectives are, first of all, tackle a major problem that people with Parkinson's have, which is gait disturbance or freezing of gait, which is seen in advanced Parkinson's. And Dr. Patrick Whelan's and Dr. Zelma Kish's lab are working on potential new targets that can help with freezing of gait, and which are not as dramatically affected by the basic pathology of Parkinson's compared to, for example, the dopaminergic neurons that we know are lost in the substantia nigra in Parkinson's disease. So we can still use this target as a viable target for neuromodulation. And also the same, Dr. Kish's group is also studying on why some patients who undergo complicated, who undergo deep brain stimulation without any issue, without any complications, the traditional DBS targeting the subthalamic nucleus, why do they decline within 5 years while others remain well for much longer? And again, this may be due to answers that can come from analyzing the brain signals from the DBS target, and this is what Dr. Kish is interested in. Focused ultrasound, this is a new neuromodulation technology that is used now routinely to treat particularly tremor creating lesions in the brain. But we now have the possibility to use this as a non-invasive or minimally, or I would say completely non-invasive a neuromodulation technology called low-intensity focused ultrasound, where we don't create any lesion, but just modulate the activity of the brain targets. And this is live. This is an image of the machine that my colleague Dr. Sam Pichardo, our physicist, in collaboration with Dr. Bruce Pike, who leads the focused ultrasound program in Calgary, has developed. We now have paradigms that have demonstrated that this process can modulate brain function in a consistent manner. But the most important advantage of this technology is that we can reach, theoretically, very deep regions of the brain that we would not be able to reach other than with surgery. But low-intensity focused ultrasound is not surgical. It just goes through an intact skin. You don't even need to shave to reach these deep targets. And these deep regions are involved in a number of different crucial functions of our brain, from motor control to cognitive functions such as executive functions or emotional regulation, including mood problems, OCD, impulse control issues. And at the moment, we are focused as a first application to Parkinson's disease that we are aware of is looking at tremor predominant Parkinson's, targeting with this technology the same target that we would operate on with DBS or with high intensity focused ultrasound to treat essential tremor or other types of tremor. We are going to now investigate the efficacy of LIFU on tremor in people with Parkinson's. This is what we are about to restart in the spring after an upgrade that our MRI scanners have undergone in the winter months. Another important point is the massive and important work that my colleague Dr. Veronica Bruno is conducting in her Parkinson's Pain and Wellbeing Lab in Calgary. As you can see, this is a list of different studies that this group is conducting, and it moves from understanding better the nature and the mechanism of specific cumbersome symptoms in Parkinson's, like pain, for example, to better understanding women's health in Parkinson's, understanding some important complementary treatment approaches, like the use of cannabis or the use of psychedelics, and asking people living with Parkinson's how do they perceive the opportunity of using psychedelics to treat some symptoms that are related to Parkinson's, how to maximize the efficacy of botulinum toxin to treat salivary drooling or foot dystonia, amongst other things, with botulinum toxin, and a very important work of the Advanced Care Team Program, or ACT program, is focusing now in our movement disorders program in Calgary on quality of life and how to and optimizing coping strategies in people with Parkinson's and their care partners in the advanced stage of the condition. There's also, and I'm going to close with this, work being undertaken on how to improve in-hospital care for people living with Parkinson's disease. And this is really a project that Dr. Bruno and I are co-leading, and together with other colleagues, which has been funded by Alberta Health. And we know that patients with Parkinson's can be admitted to hospital, obviously, for a number of reasons that sometimes are unrelated to neurological reasons, like falls or infections or delirium. Unfortunately, data, not just in Canada, but pretty much worldwide, show that there are specific risks that people with Parkinson's ending in hospital may have to face when they are admitted into medical wards or hospitalist wards, including some changes in the timing of administration of medications or administrations of agents that can aggravate symptoms of Parkinson's. And this may ultimately lead with poorer outcomes if not well controlled. There are recommendations that the Parkinson Foundation has developed in this respect, and we are actually leveraging the new electronic patient record system that we have in Alberta now. We've been having it for about something less than 2 years now, or 18 months, the EPIC, or Connect Care system, in order to really design a process that optimizes safety of patients with Parkinson's when they're admitted to hospital, in order to minimize any kind of issue with medication administration and timely evaluation of the different problems that they can manifest in hospital, including the non-motor symptoms, problems, mobility issues, speech and swallowing issues. And this is an ongoing project that we hope to be able to complete in about 9 to 12 months from now. So this was just a snapshot of what's going on in Calgary in Parkinson's research. It's not a comprehensive or exhaustive list of work, but it's just some examples that I hope you might have found interesting. That was all from me. Dr. Ba.
Very nice talk, Davide. I actually learned a lot, especially with the fecal transplant. I know in IBD they're doing that. I don't know how soon we can do it, and what kind of clinical benefit we can see. That's very interesting.
Yeah, I mean, like our approach is a bit different, because we would like to be able to, just to design an intervention that is more specific to a particular subtype of Parkinson's that patients manifest. But again, it's maybe a little bit longer, but hopefully a little bit more accurate and precise. But thank you very much. Yeah, I'll shut up now.
Thanks. So as Emma introduced, I am one of the members of the Parkinson Movement Disorder program at U of A. And I take a little bit different approach compared with Dr. Martino. And what I'm going to do, I'm going to touch on the clinical research side and let people know what we do here. And potentially, if you're interested, you can get involved in some of the research and can even directly connect with the research associate. I will leave the number there. So same as the Calgary team, for any patient care and clinical research or research is always the teamwork. So I just show a snapshot of our team, including our physicians, our nursing staff, management, the physiotherapy, occupational therapy, dietitian, and pretty much everybody in the team. We are quite enthusiastic about the Parkinson's research at PMDP. To define, I always say I even ask my resident, how do you define this? How do you define that? So for clinical research, these are very comprehensive studies of the safety and the effectiveness of the most promising advances in patient care. Obviously, clinical research involves people and who will volunteer to help us better understand the medicine and health, not necessarily will help the individual per se, but helps the big, the society for the given pathology, given disease or condition, and how we as a scientist to advance the knowledge and improve treatment down the road. This is not just limited to a medication or drug. It can be a device, some tools, diagnostic tests, some techniques, technology used in medicine. In my mind, as a physician and a researcher, I think involving in research is a privilege for both a researcher and for patients. First, I'm going to talk about a couple projects we are involved. Dr. Martino mentioned about the Canadian Open Parkinson Network, and both Calgary and us are part of a C-Open network. This is the biggest registry in Canada, run by Parkinson Canada. And so far, there are close to 2,000 participants at 11 sites and about, I think, 40 investigators. So not only you can register to the network, the data collected can inform other studies, and the people can get back to you to ask you whether you are willing to participate in further studies. Parkinson Foundation, and again, both of our centers are Center of Excellence of Parkinson Foundation, and we are heavily involved in the Parkinson Foundation research project. For example, we have been presenting on depression, genetics, and palliative care at the AN annual meeting, and we have been one of the 5 sites screening and treatment of depression in Parkinson's disease. And we are transitioning into the PD generation, which is the genetic diagnostic in Parkinson's disease. And there is an international consensus statement for rehabilitation care in Parkinson's, and we are one of the centers. The CCNA is the Canadian Consortium on Neurodegeneration in Aging. Dr. Camatrulli in our center is the PI for Team 8, which is Lewy body disease, including PD and the related conditions. So for this, I believe we have University of Toronto, University of Saskatchewan, us, and other centers. And we have multiple monthly meetings and going through and published heavily in this. One of the study right now, we are actively recruiting, also a multi-center study, is called the SPARKS. which is the exercise for Parkinson's, moderate intensive exercise in Parkinson's for those early diagnosed Parkinson's patient without taking medication yet and not going to take medication within the next 6 months. So if you're interested and if you are fitting into the criteria, I have the number right there. If you don't have time to write it down, go to our Facebook, Parkinson Movement Disorder, PMDP, U of A, Facebook, and information is right there. I go to each individual physician researcher's portfolio, talk a little bit of their interest and their productivity. Dr. Kamasholi is one of our senior researcher, and his particular interest is in neuroimaging with Parkinson's and related disorder using a local, national, and international data set. In particular, his work not only related to Parkinson's disease, also vascular disease and established methodologies with Dr. Smith at U of C, and using AI and machine learning tools with U of C Dr. Monchi. He moved to Montreal right now, and Dr. Fokkert. And with also between Dr. Kamasholi and I, we have some collaboration as well. And he also focused on gait fall and working with his colleagues had the world fall guidelines established and published already. And he also have interest in non-motor neuropsychiatric outcomes and non-pharmacological interventions, which I just mentioned about the SPARCS exercise regimen for Parkinson's disease, and multi-domain interventions in mild cognitive impairment. And he followed this patient, including patient progress into Lewy body dementia. Just a couple pictures to show the cool stuff he is doing. And so at the left side, one of our senior residents, she's actually returning to our center this fall, Nabila Nathu, and using the iron imaging and to look at different centers of the brain. What's the difference between Parkinson's disease with normal control? And he has pretty nice techniques to track certain structures, white matter tracks in the brain, and also looking at the memory centers in the brain. And these are some of the examples he does with the neuroimaging. For the white matter hyperintensity, usually that represent a small vessel disease, for example, people with high blood pressure, diabetes. So you have this white spot in the brain can change that if there's too much of these mini strokes accumulate, people can have gait and balance issues. So his research involving in this side as well. Switch gear a little bit to talk about neuropalliative care for Parkinson's and related disorders. Dr. Janice Miyazaki is really a champion in the field of neuropalliative care in Parkinson's disease. Dr. Bettino mentioned about Dr. Bruno at U of C, and Dr. Bruno worked with Dr. Miyazaki when they were both in University of Toronto. So Dr. Miyazaki is quite active and is a head and shoulder in the field. She published quite intensively, and the concept of palliative care in Parkinson's disease is not about the old concept. Cancer patient are dying, we're talking about palliative care. So we're talking about a progressive degenerative condition, and in what kind of a multidisciplinary or interdisciplinary approach to improve people's quality of life. And as you can see, and this is a couple examples of her publications over past year. And she is the 2023 recipient of the International Neuropalliative Care Society Lifetime Achievement Award. So we're really proud of her achievement. Myself, As Emma introduced, my primary practice is in deep brain stimulation. And currently I'm doing a couple project in how to access to DBS. What is the best way in access to DBS that include gender and ethnic disparities in access to the service, and also how to define the timely access to DBS, and to, in this process, to evaluate the barrier to DBS surgery. And I also am interested in multi-modality MRI analysis of Parkinson's, particularly with gait impairment. And as Dr. Martino also mentioned, that DBS doesn't treat everything. Particularly, it's quite difficult to treat gait. Freezing of the gait, for example. So we are looking at different locomotion centers in the brain. Working with my collaborators, for example, Dr. Martin McEwen from UBC, we are looking at other stimulation modalities like TMS and galvanic vestibular stimulation for the gait as well. We also have established some digital health tools for Parkinson's Parkinson's assessment. Quickly, just to give us some example of the DBS access, which is dear to my heart. For both U of A and C open data, if this is unknown data after we talked, try to call the patient multiple times, we don't obtain the data. You can see European descent of white individuals are majority of the DBS recipients, greater than 80%. And again, looking at ethnicities here among the recipients, you can see pretty much these are all like 88% European descent. Again, another example is to talk about time needed to access the DBS. Here is before the COVID-19, and day 0 marks the day I see the patient after the levodopa challenge and decide that they are a good candidate to go through. And our neurosurgeon basically sees patient within 70 days, sometimes within a month. And then you can see neuropsych, psychiatry, OTPT, and the MRI done. Within less than 200 days, we have most of the workup done, and the surgery is right here, about a year, 380 days. COVID, during COVID and post-COVID, actually there's a significant impact. The average day to hit the OR door is about 883. During COVID is the same compared with post-COVID. We are far from recovered yet. So the resources used can be an issue, and how we can keep up is a big problem. And we need to look into different barriers for such a necessary access, because patient can lose their candidacy with such a long process. And I won't talk too much about these. These are several papers we published with me either being the senior author, most of senior authors, and talk about different MRI modalities in Parkinson's, particularly with gait. Dr. Sikorsky. Dr. Sikorsky is she spends more effort in Huntington's. He is our Huntington's expert in the program, but she also has an interest in genetics of Parkinson's disease, including predictive testing for Parkinson's and gene therapies in movement disorders. And she has been running the Dudoba program in Parkinson's patient for the longest time. And currently, Dr. Shetty took over the DOBA program. And she has multiple publications on the global genetic Parkinson's disease study group and such kind of similar ones, prevalence of Parkinson's disease in Ukraine. In addition, our functional surgeon, Dr. Tejas Sankar, his principal clinical interest is neurosurgical management of patients with Parkinson's disease and other disorders. He is also an imaging expert, and he's using multiple modality imaging and neuropsychiatric techniques to study the impact of brain stimulation on plasticity on the nerve system. And a couple of years ago, he got a grant about motor state on post-activation depression of the soleus. So we use the superficial H reflex of the leg to predict and how deep brain stimulation works, and to correlate with dopaminergic medications. So we were involved in that. It was a pretty cool study. I think I finished my part of it. May sounds a little bit rushing. And as I said, focus a bit more on the clinical aspect. And I thank Parkinson Association Alberta, Leila and Emma give us this chance to talk about our research projects these days.
Thank you. And thank you for all the research you guys are doing here in Alberta. We have a couple questions. So the first one is for Dr. Martino. Is there research at present investigating the more accessible dopamine neurons at a cellular level outside the brain, perhaps in the kidney or the gut, assuming this may allow for biopsy and other methods that are not possible in the brain?
This was originally the approach that was undertaken a few years ago, but now all main neuroscientists are interested in actually investigating inducible, what we call iPSC, which means inducible pluripotent stem cells. So we can actually reprogram stem cells that can be obtained from the periphery very easily, including from the blood, and repurpose and reprogram them with genetic techniques to make them become dopaminergic neurons in the lab. And this also is, as you can imagine, becomes particularly important when we are studying the effect of genetic mutations, because we can have specific stem cell lines coming from, carrying different genetic variants. So this is work that obviously Scott Ryan, for example, in Calgary, who is our hardcore molecular neuroscientist in Parkinson's, and was interested in studying alpha-synuclein aggregation, is doing. And this is a technology that is now being used pretty much everywhere. Of course, it is interesting to study other cell types from other tissues if you want to investigate the function of the involvement of those systems and tissues in Parkinson's. For example, if you want to study the role of the gut epithelia, for example, the gut cells, specific gut cells, we need to do biopsy there. But generally, if we want to investigate the relationship between the genetic background of a specific group of patients and dopaminergic neurons, using stem cells is probably at the moment the best option technologically that we have.
Okay.
Can I also add to that question?
Yep.
So there has been a consensus committee, and in 2023, I think the diagnosis of Parkinson's is getting a lot more complicated. Dr. Martino and I actually touched on that. So in the MDS Movement Disorder Society meeting, talk about using like seed amplifying assays, and also biopsy can be done in the gut, can be done in the skin. All of these are research bases. When we talk about diagnosis of Parkinson's disease, we're not talking about using a piece of skin tissues to diagnose Parkinson. So we said the seed amplifying assay is still spinal fluid, but there are newer research talking about in the blood, potentially that can be established. And the skin, that scan, I think people now very familiar with the dopamine transporter scan. So all these to support the diagnosis of Parkinson's disease and the staging classification. In clinical practice, it's basically we assess the patient and look at their natural history and to diagnose.
Thank you. We have another one here. I'll leave it open to you guys who wants to answer. What is sporadic Parkinson's?
I think it may have been because I mentioned sporadic. We use the term sporadic to mean a patient or patients who with a diagnosis of Parkinson's who do not have family history of Parkinson's or do not have a clearly ascertained genetic cause for their Parkinson's. So it's essentially non-familial cases. But this doesn't mean that genetic makeup is not involved, obviously. It's pretty much always involved to some degree, but we can't establish for people who have sporadic Parkinson's disease what is the genetic variant that predisposes them to have Parkinson's. It's medical terminology. Sorry for that. It's a little dry medical terminology.
Thank you. Okay, Dr. Ba, you mentioned a lot about gene therapy and genetics for Parkinson's. Is it something that's available to patients or to clients already? And would it be available to family members?
I don't think so. From the treatment perspective, Dr. Martino can correct me if I'm wrong. I mean, on the clinical ground, what can be done if people have a genetic form of Parkinson's disease, especially established? What we can do, we offer genetic counseling and genetic testing, no minor, only in adult population if they want to do. And in real life, actually, a lot of patients not interested, even you offer. This Parkinson's disease is different than, for example, Huntington's disease. And there's pretty decent treatment. People can have a good quality of life for decent amount of time. Yeah, I haven't seen a lot of people want to go unless it's very early onset of Parkinson's and they have a significant dystonia. Davide, your experience?
The question is how to use genetic screening for therapeutic purposes. And I mean, at the moment, we, as Dr. Ba said, we don't have a direct, immediate solution, a therapeutic solution that is different from for patients who have a genetic form of Parkinson's compared to those who don't, for whom a genetic cause has not been ascertained. However, I did refer to the type of research that is happening, for example, in Calgary. So my colleague Dr. Aquino and Dr. Jocelyn and Dr. Park are interested in this concept of drug repurposing. So, and this drug repurposing is particularly applicable when we have a genetic form of Parkinson's. We understand what some of the key mechanisms that are involved in this genetic form of Parkinson's, and then we identify medications that already are available that can mitigate or can counteract the mechanistic the abnormality that this genetic mutation brings. So this is what my colleagues would like to do with finding medications that inhibit phagocytosis, which is related to LRRK2 Parkinson's, for example. And so that, I think, in my opinion, is going to be where the field is going to go to. I mean, we understand the specific mechanism for a genetic variant, and then we find medications either already existing, and if not, to be developed to counteract the specific mechanisms. What happens is that sometimes when we identify a mechanism of that kind, we can see it also in people with Parkinson's who do not have that variant. And this is very exciting and interesting because I think that genetic screening is always a good thing when there is family history, and it's a resource that we always encourage, because even if there isn't a clear solution for the outcome of that genetic screening immediately, there could be in the future, or it could really help the community to learn more how to deal with specific genetic variants of Parkinson's.
Yeah, I totally agree on that. That's a part of precision medicine, right? It's for even just for the academic purpose as of today is very important.
All right, thank you. I have a couple questions about Vyalev. So I don't know, Dr. Martino, if you want to take these ones. Do you know roughly when it might be available to patients? And when it is available, will they move away from Duodopa more toward this? Will those who have Duodopa be transitioned over? Are these questions you can answer?
I think it's pretty much already available in both Calgary and Edmonton. I mean, we are at a in Calgary, we are at the very final stage of getting started. So we are just fine-tuning the flow, the workflow that we need to perform, we need to undertake to make it accessible to patients. It's still, however, there's an issue with reimbursement at the moment. At the moment, coverage is still being sorted out. So it's available in theory, but in terms of broadly available from a coverage perspective, that is not something that we are already at, but we will be hopefully at in the next few months. I mean, 2-3 months. I'm sure that this will be solved. And the other question was, maybe Dr. Ba, I don't want to answer every. What was the other question?
Will it replace Duodopa? So those who currently have Duodopa, will they be replaced to the system? And is this kind of what they're thinking going forward to use?
Well, Duodopa has a longer history, right? Then Duodopa is good to eliminate off time better on. It may not be the best for very, abrupt dyskinesia, disabling dyskinesia. I think the sub-Q pump, as Dr. Martino said, the on will be good. The dyskinesia, we don't have that much data yet. Thinking about pharmacokinetics, it might be similar to Duodopa, but the better part is it doesn't, although the jejunum, the first part of where the tube goes in, right, the small intestine, is where the drug is getting absorbed. Wherever the gut is involved for absorption, it still can be interfered by the food and other things. And for the sub-Q pump, this is not the issue. So easier to
independent, maybe.
Yeah.
I think it's a learning curve, but I think one thing for sure, we will consider it sooner, probably in the course of the condition compared to Duodopa. We might consider it a bit sooner because it's less invasive. It doesn't require surgery, and you can discontinue it at any time. Of course, so the Duodopa, you can also discontinue it, but it's a little bit more laborious to discontinue, requires more surgery or more simple surgery. But so it's we will learn whether they are truly complementary or whether one will replace the other. My bet is that they will be complementary. They will not the subcutaneous pump will not replace Duodopa, which I think is a bit what Dr. Ba was saying. I mean, I think we agree on this.
That makes sense. Yeah. I know it is 1 o'clock. Do we have time for one more question?
Sure.
All right. Are there opportunities in Alberta for a person with Parkinson or Parkinson's plus to donate their brain specifically for research?
Can I speak from the UFA side? We actually don't have like a Parkinson Lewy body pathology program, as far as I know. However, there is a neuropathologist at UFA, and just gave a grand round talk, and said we are more than happy to appreciate this kind of a donation of the brain to advance the understanding and the science. Yes, UFA, yes.
Yeah, same for you, University of Calgary. We don't have a brain bank that is specifically dedicated to Parkinson's, but we do have a brain bank, a brain repository for neurodegenerative conditions, and yeah, it's definitely possible. And of course, we would do everything that it's in our ability to facilitate that and make that happen. If this is a wish for if this is a patient's wish. In fact, I mean, I think that we will be I think generally speaking across Canada, there will be an increment in campaigning for brain donation. I can anticipate that, particularly for other conditions a bit more rare than Parkinson's. For example, PSP, there's a very strong endeavor to create a Canadian brain bank, which is currently based in Toronto, but I guess we could all contribute to that. But yeah, it's always a donation of incredible value.
No. All right. Thank you so much, Dr. Martino and Dr. Ba, for coming and taking the time and sharing your knowledge and sharing what your teams are doing. It's amazing to hear what's happening here in Alberta.